Thank you everyone for joining us today for the CTSI's Translational Science Seminar. I'm going to pass the torch to Orfeo Buxton, who is faculty up at Penn State and one of our associate directors for CTSI, to do formal introductions.
Thank you, Ellie, and good morning, midday, everyone. It's my honor today to introduce to you Dr. Julie Wagner, professor at the University of Connecticut School of Dental Medicine and Medicine. She's a licensed clinical psychologist with a program of research in behavioral diabetes. Dr. Wagner partners with community agencies to design, implement, and test culturally based community health worker interventions to prevent or control diabetes in low-resource settings in the U.S. and abroad. Her work also examines the role of mood stressors and social determinants of health on psychophysiological responses to mental stressors. Her work has been funded by the NIH, the American Diabetes Association, and the American Heart Association, and I've been honored to call her a collaborator for over a decade. Dr. Wagner has served as an associate editor for leading behavioral medicine journals, has held leadership positions in the ADA, American Psychological Association, and the Behavioral Research and Diabetes Group Exchange, or BRIDGE. Without further ado, Dr. Wagner, thank you for joining us today.
Thanks, Orfeo. It's a pleasure to be here. Thank you to the rest of you who I imagine you're probably eating your lunch and cramming this into an otherwise busy schedule. So thank you for doing that. I'm going to go ahead and start by trying to share screen and make sure this all works. How's that look?
3 slides.
How's that?
1 slide. Perfect. Thank you.
Excellent. Okay, great. Yeah, Orfeo and I have worked together on some really fun and interesting projects, and it's been a great collaboration. And so I was super happy to say yes when he invited me here today. So the title of my talk is Community-Based Research Supporting the Expanding Role of Community Health Workers, or He Who Doesn't Know the Eagle May Grill It, Thinking It's a Chicken. So this is an Arabic saying, which basically means know who you're dealing with. Know the person in front of you, because if you don't do that, you may make some mistakes. And what I'd like to start off by saying is that doing this kind of cross-cultural work, particularly as a white European woman, can pose some challenges and can be filled with trepidation. You may be afraid of being viewed as racist and so forth, cultural appropriation. But in fact, I have found that this work to be really joyful. And that's despite the fact that health disparities are, of course, one of the greatest immoralities of our time. I started doing this work because I cared about diabetes and behavioral diabetes. And the more that I got into the field, the more that my motivation was sustained by wanting to understand and help ameliorate some of those health disparities. So my focus has shifted a little bit. But despite those health disparities and the very, serious work that this is, our work doesn't have to be solemn or depressing. And in fact, it can be filled with a lot of joy. And I don't know about you, but my work is not filled with joy because of the IRB or because of funders or because of university administration. I get my joy in my work out of these cross-cultural interactions, particularly with community health workers. And I have found that these idioms and proverbs from different cultures that I've worked with are a wonderful window into understanding and having fun with those communities. I've had the incredible good fortune of working with really rich, interesting cultures that are different from my own. Abroad, I've worked in Vietnam, mostly in Cambodia, also in the Arab world. And here in the US, I've worked with, excuse me, Puerto Ricans and Cambodian American refugees. I won't be talking about my international work today, although that's really fun for me to do that, but it's outside of the scope of what I'm going to be talking about today. So I have no disclosures. The funding from some of the data that I'll be presenting are from these sources: University of Chicago, the ADA, and NIH. So my goals for today are fairly modest. I want to provide a rationale for employing community health workers as part of the research team for diabetes research in minoritized communities, list some of the benefits and challenges of community health workers collecting various types of research data, present qualitative and quantitative data from 2 randomized controlled trials that employed community health workers as data collectors with Puerto Rican and Cambodian American communities, and provide some suggestions for doing this work. And Orfeo, what I'm going to say is that in order to see my screen, I've minimized the Zoom boxes. So, but I would love to field questions along the way or hear comments. So if there are any, Orfeo, could you sort of manage that, or Ellie?
Happy to do
be
that.
great.
I will step in when there's a question.
Great, thank you. So I'm sure you're all aware that rates of diabetes are disproportionately high among minoritized groups. And the behavioral risk factors for diabetes, I'm a health psychologist, as Orfeo said, by training. So I'm really interested in the behaviors and the psychological experiences and exposures that increase risk for diabetes or for poor outcomes of diabetes. And these behavioral risks for diabetes are not commensurately distributed across different groups. So for example, we know that low socioeconomic status and mental health disorders are risk factors for type 2 diabetes. And those vary by population. And some sub-ethnicities are particularly vulnerable. So here we see rates of diabetes by race and ethnicity. And what you'll see is that, sort of Hispanics are here in the middle, Asian Americans are down towards the bottom, but that is clearly not the whole story. Just having a hard time advancing my slides here. Okay. So if we look at diabetes by Hispanic subpopulations, and this is the National Health Interview Survey in 2009, and the data look similar more recently, you see that the bar for Puerto Ricans is the highest, and quite high compared to, for example, Cubans who are more like non-Hispanic whites. Diabetes across the Asian subpopulations. Now here we don't see Cambodian Americans, and they should be represented in the Southeast Asian bar, which is 18.7%. I don't know if you can see my cursor, but this orange bar here. But in fact, what we know is that among Cambodian Americans, it's more like 28 to 29%. So there is variability, not just within sub-ethnicities, but then even more granular sub-ethnicities. So this is just a plea to do what we all want, which is to collect data on a granular level and to encourage the policymakers who control what's collected through our electronic health records to be willing to dive deep into some of these granular data. So socioeconomic status, we know, is a strong, low socioeconomic status is a strong risk factor for type 2 diabetes. And these are data from the Whitehall study. And what we see on the left here, the blue bars, are high, medium, and low SES, what's considered cumulative SES, so over the course of your lifespan. And then on the right, the bars represent the life course trajectory. So does your SES status change over the course of your life? And what you see for cumulative SES is that low SES has the highest incidence of diabetes. And similarly, along the life course, people who start out low SES and stay low SES have the highest incidence of type 2 diabetes. A really good and important indicator of SES is food insecurity. And it's particularly relevant for type 2 diabetes. The association is quite strong. And here what we see is prevalence of food insecurity by severity, and for Hispanics by immigration status. So it's a little bit confusing, but basically you have naturalized citizens, people born in the United States, born in Puerto Rico. These are people who do not have citizenship, non-Hispanics on the bottom. And the two different bars that are horizontal represent very low food security and low food security. And really the punchline here is that people born in Puerto Rico, now living in the mainland United States, have the highest rates of very low food security and low food security. Despite being American citizens, they have the highest rates among Hispanics of food insecurity. So we talked a little, oh boy, my phone's talking to me, sorry. Sorry about that. So we talked about socioeconomic status. Now let's talk a little bit about mental health as a risk factor for type 2 diabetes and particularly depression or depressive symptoms. And we know that depression is associated with all stages of diabetes. So starting on the left here, odds ratio at the top, and the life course, the natural life course of diabetes across the bottom here. So pre-diabetes, diabetes, once you have diabetes, suboptimal glycemic control, long-term complications of diabetes, and then eventually mortality from diabetes. And across that whole natural life course of metabolic dysregulation, depression exerts a deleterious effect on poor outcomes. But depression is not equally distributed. So when we look at depression by Asian subethnicity, all the way to the right here, we see Chinese Americans, and they have what we might expect from the general population, which is to say somewhere between 10 and 20% lifetime major depression. But if you go all the way to the left here, look at the Cambodians. They exceed 50% lifetime major depression. So when we think about care and interventions for the neediest people or the most at-risk people, we really need to get down into some of these more granular data about who is most at risk. So the communities most in need of diabetes prevention and care, due to a heavy burden of risk factors, they may also have other vulnerabilities. So low literacy and numeracy, perhaps a fear of research, a lack of confidence in or mistrust of academic and medical establishments, multiple barriers to engagement such as language and transportation. So this is where the community health workers come in. So Orfeo and I have a collaborator, Angela Bermudez-Millan, who is Puerto Rican, and she taught me the phrase, "Only the spoon knows what's in the pot." So there are certain things that can only be fully understood by those who are directly involved. That's where the community health workers come in. So I'm sure you're aware a community health worker is a frontline public health worker, typically bilingual and bicultural, a trusted member of the community that they serve. And they serve as a bridge between health services and the community. And we are using them as a bridge between research and the community. So CHWs traditionally do things like they increase access to care through insurance enrollment. They may engage patients in care through language interpretation. They may extend services by making referrals to social services. So in a medical healthcare setting or in a social services settings, these are the kinds of things that they are typically doing. They are not mere helpers to higher paid personnel, right? So they're not assistants, and they should not, in my mind, be employed for downward task shifting. They're not there because they're paid less to pick up some of the grunt work. Rather, they have a unique skill set that cannot be provided by most academic members of the team or most healthcare professionals. And we are showing there's a huge body of literature with strong evidence for community health workers in things that I was describing, like engagement and retention and so forth. But there's very little known about community health workers in a research context, and particularly doing things beyond just outreach. So we are interested in actually integrating community health workers into the research team in a meaningful way. And we have had community health workers that collect quality data. They know where to access hard to reach populations. They behave in a culturally appropriate manner for the population. They approach the hard to reach populations, socialize them to research, engage them in data collection, administer measures. They can increase protocol compliance and minimize missing data, provide language translation. Really importantly, for some cultures, interpreting idioms of health, illness, and distress, relate findings to the research team and put those findings in context, and notify the research team when a measure is not working. They're seeing it firsthand. So I'm going to talk about two studies where we have, where community health workers have conducted data collection. The first is Community Health Educators Assisting Latinos Manage Stress and Diabetes, or COMS-D. You see the research team down here at the bottom. A few of the community health workers are here. So we have Ruth, who was a certified nursing assistant, recently came from Puerto Rico. Minky, who is a phlebotomist and born in Puerto Rico, has lived most of her life here. Josefa, who was born in Peru, and another gentleman who is from Central America. So this is the group of community health workers. This was a two-armed trial. I'm not going to get into like the results of the studies. I'm more interested in telling you about how community health workers were working in this study. But this was just as a bit of background. It was a two-armed RCT comparing diabetes education to group diabetes education plus 8 sessions of group stress management. And the folks were all Hispanics with type 2 diabetes. The vast majority were Puerto Rican from inner city Hartford. And the main outcomes were depression, A1C, depression and A1C. And there's no secret, what we showed was that depressive symptoms decreased more in the stress management group, and that there was a dose effect response on A1C, so that people in the stress management group, their A1Cs reduced more as they attended more stress management sessions. The second study I'm going to be talking about is DREAM, and this is a study that Orfeu and I collaborated on. This was a study for diabetes prevention among Cambodian Americans, also had community health workers doing data collection. Both of these studies also had community health workers doing the intervention, but I'm not going to be talking about interventionists today. I'm just going to be talking about data collection. So in this study, you can see 2 of our community health workers. Linda over on the right, who actually, I don't know if you can see this Christmas cactus behind me, but she gave that to me years ago and it still keeps blooming. So that's really lovely. and Savut, who's sort of in the middle here. Both were born in Cambodia. Their first language is Khmer. Linda could also read and write Khmer. Savut, like most women of her age, of her generation, could speak and understand Khmer, but not read and write Khmer because she had not gone far enough in her formal education. Most women in Cambodia stop education in the 6th grade. This was a 3-armed trial where we compared social services as the control condition to a group lifestyle intervention, to that same lifestyle intervention plus some sessions with a pharmacist to optimize medication therapy. And these were folks with elevated risk factors, Cambodian Americans with depression and elevated risk factors for type 2 diabetes, but they did not yet have diabetes. And we were looking at the progression towards diabetes. So we looked at the outcomes for A1C, insulin resistance, and depression. We found that A1C, there was a group difference for A1C, and the group that met with the pharmacist had the greatest reduction in A1C. Both intervention groups improved on depression compared to the control group that received social services, and there was no effect on insulin resistance for any group over time. So let's talk about these community health workers. How did we find them? How did we select them? Well, let me talk a little bit about state law about community health workers. So in Connecticut, the CHW Advisory Committee put in place a certification program. And I looked online right before this presentation, and Pennsylvania also has a certification program, which you are probably well acquainted with. Here in Connecticut, you have to be over 16 and either attended an approved training program, which is available at several of our community colleges, and have 1,000 hours and professional and community references. Or in the absence of the training program, you can have 2,000 hours. They're required to have 30 hours of CE every 3 years. And just this year, the Connecticut legislature passed a bill to reimburse CHW services for Medicaid patients. So that was a big step forward. So having said all of that, in our studies, only one of the community health workers was a certified community health worker. Like a lot of certification, it's important, and it's particularly important for reimbursement, but it doesn't necessarily get you exactly who you're looking for to fill a particular role. So we're really more interested in the desirable qualities for a community health worker, not necessarily certification, although they're not certainly not mutually exclusive. Someone who's connected to the community, either a member of the community or a close understanding of it with shared life experiences, friendly, outgoing, and respectful, courageous, mature, prudent, and honest. I mean, these are like things you want in everybody, right? You want them in your coworkers, you want them in your spouse. Caring and tolerant, motivated and persistent, capable of self-directed work, dependable, flexible, and responsive, creative and resourceful. So when we're thinking about people who do this work in a study, it's less about certification and more about these kinds of qualities. In our studies, the community health workers are not employees of the university. They're employees of a community-based organization that we have a relationship with and who we've financially contracted with, we being the university. So that's beneficial for a few reasons. Usually we're recruiting in part through a community-based organization. So if recruits see that the community health worker is an employee of the CBO, there's some built-in trust already right there, rather than if they were employees of the university. We do make sure to co-write the job description for the CHW with the community-based organization so that the research team gets the skills that we need and the qualities that we need, and the CBO gets a community health worker who fits into their organization well. Their direct supervisors for day-to-day scheduling and that sort of thing are usually at the CBO. And sometimes these are part-time people, right? So they're managing, working for the study part-time, and the rest of their full-time is spent on programs through the CBO. And we couldn't possibly manage all of that and deal with all that, but their supervisors at the CBO can do that. They do the recruitment, the interviewing, the hiring, the firing, and all the internal communications. This was a little bit of a surprise to me at one point. It was early on in the DREAM study, and I just got an email that said that one of the community health workers who I had never had any kind of issue with whatsoever had been let go. And I frankly never received the details of that. And at first I was like highly offended and really felt like this was not going to work. If the supervisor at the CBO could exercise that kind of decision making without consulting me. And upon further reflection and more conversation, I really realized that they really needed the ability to do that it was not my decision, it was their decision. It created problems for the research study for sure, but it was not my decision. The other reason for having the community health workers employed by a community-based organization is job security. So if we're hiring them onto a research grant, the grant ends in 5 years, they need a way to continue, and the CBO is more likely to have a position for them than I might be on a future grant. Okay, so that's sort of how we select them and get them employed. Now, how do we train them? This is where the fun begins. So Kamai say drop by drop fills the container. So these are little handmade bamboo containers that are on a tree that collects the sap from the tree slowly over time. So these things may hang there for days and weeks before they're filled, but eventually they do fill. And so the message here really is go slowly with the training. And no matter how much time you think it's going to take, this was my lesson learned, no matter how much time I allotted, it always took a little bit more time than I had expected. It's time intensive, but it's a really good investment, and it's bi-directional because the whole time your team is training these community health workers to administer the surveys, we're learning effectively how to work with interpreters, and we're learning all kinds of stuff about the culture that we may not have known before. And for both, we're both learning about cultural patterns of deference, of face, of conflict resolution, things that are going to be really important for us working together as a team that we may not know going into that, but we're learning it through informally. We're learning it just through our interactions during the training.
Julie, if you wouldn't mind, could you say a little bit more about FACE? For example, comparing the US researchers and the Cambodian community health workers and what you meant by that?
Sure. Yeah, absolutely. So face is a matter of like how you represent yourself to the world. And it's very important to save of course, there's a lot of individual differences and there's no like pan-Asian culture, but generally in Asian cultures, face is very important and not bringing shame upon yourself, upon the organization you're working with, upon your family, and frankly, really just like not bringing shame to Cambodians. So really trying to present yourself in a way that that never loses self-respect is very important. So I may be like extremely easily go like, oh my God, I totally screwed up. Can you believe what I said? And like, that's not the way a Cambodian community health worker would present if they had made a mistake. It would be much more somber, more severe, more apologetic, and maybe not even come out at all. Right? It may not be something that they're going to be willing to volunteer at all. Does that make sense, Orfeo?
That's great. Thank you.
Sure. So most community health workers are engaged in some kind of clinical or programmatic service delivery. They're not doing research, and they may be completely naive to research. And so we have to really back up and think, train about things like human subjects protection, research ethics, informed consent, privacy and confidentiality. I mean, one thing that would come up, whereas these folks we worked with were like highly ethical people who really wanted to do the best by everyone in their community. They cared deeply about the members of their community. But the idea of thinking about justice in terms of the Belmont report, that you fairly distribute risks and benefits, and opportunities for research. It was not infrequent that a community health worker would have a participant who they knew would really, really benefit from sessions with a pharmacist, and it's the idea of randomization and justice in terms of equitable distribution of benefits was hard. It was really hard. Research methods, so recruitment, screening, randomization, standardization, documentation, as well as safety, both for staff and participants. Safety for staff, community health workers doing home visits and so forth, bloodborne pathogens, all those sorts of things. And these are the kinds of things where if you're working with a research assistant in academia, you can take this for granted, right? Like, somewhere along the way, they have gotten this training, but that's not usually the case for a community health worker. So how did we train them in data collection? These are not the best slides. The next couple slides, I apologize for that. We trained them in a wide variety of data collection procedures. So for biological data collection, anthropometrics, blood pressure, we had them do in COMS-D, all the data collection was during home visits, and in DREAM, most of it was, but it could also be like at a church or a temple or social service agency. But we wanted to do these experimental challenges where we had, for example, sit to stand blood pressure, or a sustained hand grip, for 3 minutes, pre and post blood pressure, things that required important attention to posture, to timing, to really precise documentation. We taught them in those, how to collect urine samples, 24-hour urine samples, fasting bloods. So in COMS-D, we had a community health worker who was a phlebotomist, and she actually did all the blood draws during home visits. But in DREAM, we did not have that. And so the community health workers scheduled the participants and escorted them to a Quest lab to get their bloods drawn. Hair samples, Orfeo has been working with hair cortisol. And so we collected hair, also with Orfeo's sleep and physical activity actigraphy, so wrist and hip devices, heart rate variability, where participants wore Holter monitors. And I have to tell you, I went recently for a Holter monitor, and they had this like beautiful little thing that just sticks on your chest. That's not what it was like when we were doing, they had like 7 leads and the thing hanging around their neck, and it all had to be placed correctly. And yeah, so the details of Holter monitoring, how to administer surveys, so the importance of standardization, establishing rapport, reading questions, being non-judgmental, and so forth. How to do this in the home setting where there's kids and grandparents and TVs on and so forth. How to respond to participant distress and responding to questions about depression, trauma, and so forth, food insecurity. Knowing when to take a break or reschedule or discontinue an interview. We also had embedded in the COMS-D study, we had a 7-day micro-longitudinal study where people wore continuous glucose monitors and Holter monitors and responded twice daily to a phone survey. And so here you see Josefa learning how to take this phone survey so that she could teach participants how to take the phone survey. Data entry, of course, we used REDCap. That's a whole learning curve. And then sample handling and data transfer. So how to code things, mail devices, mail hair samples, and so forth. Clean the equipment, reorder them, that kind of thing. And I should say that the community health workers that we worked with were uniformly open to collecting almost any kind of data. They were not open to transferring data electronically. That for whatever reason, that made them very nervous. And I can understand, frankly, I'd be worried about losing data too, or sending it to the wrong place. And so they were fine with sort of FedExing things, but they were not comfortable with electronically transferring data. So all of those electronic files, like for Holter monitoring and so forth, all had to be done by a supervisor. So of course we had an SOP binder. We had different trainers come in for each thing. So Orfeu came in and trained about the actigraphy. Angela came in and trained about anthropometrics. I did the surveys. So they were really getting, the pharmacists came in and did how to take the medication history. So they really got top-notch training from, specialists in their field. Verbal instructions, I think, were the most important, even more than the binders. It was usually delivered in 2 languages through the study coordinator, who was bilingual. We always were continually asking for feedback. Do you think this will work? Do you have anticipate any problems? Teaching and just like low literacy, low numeracy strategies, teaching in small chunks over time with lots of hands-on activities, between session practice, easy reference guides. And when they're in the field trying to collect these data, knowing that they have real-time access to a supervisor. So when they ran into issues in the field, they knew that they had backup. So part of working with community health workers, including in collecting data, is thinking about trauma. Collective trauma may be part of the ethnic psyche for a particular group that you're working with. So asking yourself, is trauma a characteristic feature of everyday existence for this group? Because trauma responses may adversely affect attention and memory and cognition, reduce ability to focus and organize and process, interfere with problem solving. And this isn't just for participants, right? The community health workers are members of this community. And if there was collective trauma, they may have been or probably were exposed to it as well. And so an important part of the training is creating a calm learning environment. I am not necessarily the kind, so I often arrive at meetings 5 minutes late, with, like a coffee and like answering my phone or whatever. No, you're not like, this is not the way to, well, it's frankly not the way to interact with anybody, but it's certainly not the way to interact with community health workers and with members of a community where there has been collective trauma. So really creating a calm learning environment is very important, and paying attention to what's going on in the room, so that if there's a weird vibe, addressing it before you get into the training. What's going on? Can I be helpful? Is there anything you'd like to talk about before just diving into the learning, the training. So in these two particular communities, I could talk a lot. I love the Cambodian people, and they have a beautiful and also tragic history of genocide, torture, and deliberate starvation, which certainly affects, these are like, this all has to do with metabolism and diabetes, so there's a lot of issues with food. But they may also have experiences with forms, with tests, with people being labeled with a number, with interviews, with touch, with power differentials. These experiences may have given rise to fear and suspicion, stress and confusion. So just knowing that that may be at play with the community health workers that you're working with. And, hopefully the community-based organizations will be able to help determine whether, this particular person is, yes, they may have had a trauma exposure and they may have had some of these sequelae, but they are organized enough and functional enough to do the job that we're asking them to do. And I think it's very important that they help make that determination. And for Puerto Ricans, of course, natural disaster, we're all accustomed to seeing these heartbreaking pictures of Hurricane Maria. But the truth is, Hurricane Maria was just like the culmination of a long history of collective neglect of the Puerto Rican people, where 61% of children live in poverty and the unemployment rate is greater than 10%, and basic services are not provided to a lot of people despite the fact that they are American citizens. So, but coming out of these natural disasters with traumatic grief, prolonged uncertainty about loved ones, and anxiety and emotional reactivity, deficits in emotional processing, difficult trusting others, these are all things that are that can be a product of long-term neglect. And let me just say, by neglect, I mean neglect of the people of Puerto Rico by the American government. I'm not suggesting that this woman is neglecting her children. Let me just be clear about that. So being trauma-informed when working with community health workers. And this has become sort of the focus for me is, yes, these wonderful people are working on these projects and they're doing this good work, and they're, some of them are delivering the interventions and it's all good for the community. But at the same time you're doing that, you have the opportunity to create a human-centered process, right? To create a more sustainable work environment for the community health workers, for creating a safe work environment for community health workers, for creating really healthy collaboration between the research and the community health workers to help elevate their voices. So for me, it has become not just, a means to collecting data, but the relationship and the healing and the community building that comes out of working with the community health workers themselves is incredibly rewarding for me. But as the Cambodians like to say, even the four-legged elephant trips, so anyone can fumble. And certainly I've done a fair amount of fumbling myself. But it's important to have supervision in place for the community health workers, and supervision both like the real-time people at the community-based organization, but also supervision from me as the PI and from the study coordinator. There's a body of literature, mostly international, about what good supervision looks like for community health workers. Should be ongoing, supportive, have appropriate tools to track progress, have a problem-solving focus, be empowering. And the Rural Health Information Hub says a supportive, that's lay health worker supervisor is regularly available, provides supportive and trauma-informed supervision, prioritizes safety, offers monitoring and coaching to the community health workers, and dedicates sufficient time, especially for new roles. I am behind time, so I'm going to skip a little of this and just go on and give you some data. So we collected quantitative and qualitative data about the work of the community health workers in both DREAM and in COMS-D. So one way to look at it is how much missing data are there, right? This is an RCT. We need to make sure we have the data. So DREAM showed an acceptable level of missing data, which ranged from 1.5 to 11% for any particular variable. And that includes really highly sensitive survey information. So food insecurity, symptoms of PTSD, black spot and Kamak-Sankat, which are culture-bound syndromes in Khmer. Heartbreaking questions about starvation during Pol Pot, and as well as biological data. So missing data for sleep actigraphy and physical activity actigraphy. It's considered missing if there's more than 3 days missing. And we had missing data for 3.7 and 8.5% respectively for the actigraphies. And hair samples, which nobody wanted to give because nobody wanted to have, like, you know, concern about aesthetics and appearance. But that was only missing or insufficient for 7.5%. And this compares really favorably to, there was recently systematic review looking at RCTs, and for the dependent variable, for the primary outcome, the average amount of missing data was 9%. And so here we're showing, you know, comparable rates of missing data with much more difficult to obtain measures. For COMS-D, we wanted to know how accurate the data was. So for these sophisticated biological variables that were collected by community health workers in the home, you know, how close were they following the protocol? And so we created very detailed checklists and had independent observers go out and observe. This is an example of a checklist for the continuous glucose monitor. And so you can see every single step down this left-hand column of what they should be doing, whether they did it or not, any observations. And what we found was that there was greater than 95% compliance in following the data collection protocol for these, for the interactive voice response, for the hand grip blood pressure, sit-to-stand blood pressure, Holter monitors, continuous glucose monitors. So in short, the community health workers were really following the protocols when they were doing these home visits. And just a little bit of qualitative findings. We interviewed community health workers. Well, we didn't, but we had an outsider come in and interview the community health workers about their experiences in COMS-D collecting these data. And it was overwhelmingly positive. They felt that the training was good. The supervision was good. They loved the new skill acquisition. They loved learning something new. And one of the things that we know about community health workers is that it's very important to offer them career development. And so learning new skills and taking on new roles is very important to them, as it is to the rest of us. And uniformly, they said, yes, they would recommend this kind of data collection position to another community health worker. Okay, I'm going to skip the dissemination stuff, except to say that we offer listening sessions that are translated in real time to the community, because many Khmer people cannot read or write in English or in Khmer. And also creating infographics, bilingual infographics is a good way to disseminate data. And I'll just finish by saying, really at the heart of all of this is cultural humility, the ability to maintain an interpersonal stance that is oriented and understands what is most important to the other person, and is open to feedback and open to learning and understanding more. And the Cambodians say, navigate a river by following its bends, and negotiate a culture by following its customs. And I think that's pretty good. So I'll stop there, and I'm happy to take any questions.
Thank you, Julie. That was great. Now I'd like to open it up to questions. Please unmute and speak up. You can raise your hand if you want, or put something in chat and I'd be happy to read them. Do we have any questions? So Barbara Stallman writes, Barbie, thank you. Can you speak to using community health workers not as data collecting official members of our research team, but as adjunct supports of recruitment and retention and research protocols?
Yeah, absolutely. We had, yes, do it. It's fantastic. They're incredibly effective. For the DREAM study, we had, this was baseline post-assessment was at 12 months. Follow-up was at 15 months. And there were 24 sessions in the treatment groups. We had 96% compliance through retention through 15 months. And that had nothing to do with incentives. I mean, incentives help, but you know, they were just like normal incentives, whatever. It was the community health workers who had a relationship with these people and kept them engaged. I mean, part of it is tracking people down, which they know how to do better than we do. But part of it is just the engagement and the caring for the people in the research study. So absolutely, I think they're great for doing that. Supports of recruitment and retention. Recruitment, yes. And so this was, we used all community recruitment. So we went to temples, churches, businesses. That was for Cambodians. For the Puerto Rican study, we recruited out of an inner city medical clinic. So that was a little bit more standard, but it was the community health worker doing the recruitment. Once the nurse had identified a potentially eligible patient, it was the community health worker who went in and did the recruiting, not a research assistant from the university.
So Julie, just to follow up on that question, when you say, so in all those circumstances, you use the community health workers or the lay workers for data collection and throughout. So there was that higher level of engagement. There wasn't a recruitment and retention and then a handoff to another member of the research team. I'll also just point out how she is putting it is that they're not official members. Whereas what I thought you were saying was that it was important that they be truly and fully members of the team and integrated. So do you want to say more about whether you would consider them for a limited role on recruitment and retention, or the magic that you saw was more the whole process?
Yeah, I think the magic for me is more the whole process, exactly, and that you're good. I would venture to say that you would see benefit of working with community health workers that way, but it's almost more like using community health workers in that way, as opposed to working with them and having them be part of the team. So I think it would be a step in the right direction, but perhaps you wouldn't see quite the same success as you would if you were able to actually integrate them into the team. Yeah.
Good.
Thank you, Orfeo, for making that distinction.
There's another question too about barriers to see more CHWs included in publications. Do you include the CHWs in your publications, and thoughts on doing that and barriers to overcome?
That's a great point. We actually have not. We make sure that the when we're starting a research project and engaging a community-based organization as an equal part, and these are organizations that I have like years of history with. It's not like I'm showing up cold. But we always start out, one of the things we talk about is who owns the data, What is it going to be used for? Is it going to be used for advocacy, for academic promotion and scientific literature, or both? I usually like to see it used for both. And publication as well. And in most of the journals that I publish in, there are guidelines for what warrants publication. And it would be like scientific contribution. So design, selecting measures, research question, hypothesis testing, that kind of thing. And the community health workers are not involved in that. So they are certainly involved early on in sort of helping to formulate what's the problem the community wants to address. For both of these, it was diabetes, it was stress, it was depression. But they don't have the training to be involved in the scientific contribution of the study, and so they don't meet criteria. That doesn't mean that there's not other ways that they can get publication through, for example, helping to design infographics, making presentations at the Department of Health, those kinds of things. But for the typical scientific journal, the community health workers in our studies have not met that.
With the exception of the supervisor, who was a community member also.
Yes. So that's what's sort of, tacked out at the beginning, is who's going to be on what publication and who's going to be first author on which kinds of publications. So yes, the members of the community-based organization who help administer the study are absolutely involved in, get authorship for sure. But that's something for you to figure out with your community-based organization, what their needs are. Some of these people, frankly, don't care because they're not in academics and they don't need the publications. They don't necessarily want them, but it's very important that they own the data so that they can use it for advocacy purposes, or grant writing purposes to get their organization grant funding.
Another question.
Our currency as academics is peer-reviewed publication. That's not necessarily their currency.
Another good question. Harder. How do you distinguish the roles that RAs, clinical research coordinators, and research nurses have on the team?
It seems pretty straightforward. I don't know if I'm missing something, but we've had nurses, we've had lab techs, we have research assistants, and everyone just has a clear role. So research, for example, on the DREAM study, a research assistant, Cara Dion, she did all the back-end REDCap stuff, right? And she did all of the letters to providers saying, your patient is involved in a research study. And she did all the printouts of, feedback for participants about their labs and stuff, but she didn't interact with participants. So I think it can work in a variety of different ways, as long as people are clear what they're responsible for and who they report to.
I guess I would add, just from the experiences together, that there was, to add to that question, it's less about the distinction of the roles. That ends up being fairly clear, like people do the thing that they're good at and trained to do, but that you always had really good team conversations with all of the team members present, because everybody contributed. So.
Right. And so one of the slides that I skipped was the different kinds of meetings that you're going to want to have. You're going to have one-on-one review of performance. You're going to want to have one-on-one, just, where are you with recruitment and screening and so forth. You're going to want to have team building kinds of meetings. You're going to want to have whole study meetings where people can get together and socialize and understand who each other are, and small team meetings. And it's a lot of time just being with people to help them understand how they fit into the big picture and where other people fit as well. Yeah.
So, Julie, Dr. Wagner, thank you so much for this fabulous presentation. There's lots of thank yous in the chat, and thank you so much for joining us today.
Thank you. Enjoy the snow.
Take care, everyone.